Hello, everyone. It's July the 1st. It's a new month. It's a new year. And that means I'm excited about a number of things. One, I'm rounding on the inpatient service with new bright-eyed interns. And two, I'm excited to bring to you the latest and greatest in clinical research at Hepatology Communications, where I, Elliot Tapper, am co-editor in chief. So I'm perusing the list of our latest publications, and I've got a lot that I'm excited to share with you. The first is from Dr. Lizzie Abbey. This is a multi-center study where they evaluated financial burden amongst 453 patients who had undergone liver transplantation at 13 centers. They did a ton of questionnaires. They did health-related quality of life. And what we learn is that financial toxicity is common. 1 in 4, 23.3% of liver transplant patients report significant financial burden, and that burden creates substantial distress. It's not associated with a decrement in health-related quality of life, but it weighs on them heavily using validated questionnaires. There's got to be ways that we can better support people, either through guiding them through finding the lowest cost options for their medications and thinking mindfully about the kinds of tests and other hoops that we're asking our patients to jump through. Part of thriving after transplant includes one's financial health. Beyond that, we have a reminder from Dr. Jonathan Steinberg with a paper, Long-Term Protection Following a Primary Series of Hepatitis B Vaccine in Alaska Native Children. Following the 3-dose primary series, this was associated with significant protection. However, that protection lasts up to 41 years of follow-up. Only 1% of these patients had evidence of a breakthrough infection. There are few things in this world as reliable as the hepatitis B vaccine, and we're grateful to this group who's been following these patients for so very long to show the world about the safety and power of this vaccine. The group from UCSF, led by Dr. Jin Ji, is a pioneering group in understanding and implementing artificial intelligence into clinical practice and research for the purpose of improving care delivered to patients with chronic liver disease. And so one might imagine that we could simply use AI to help us wade through a number of the consults that we receive. But while that might be true, not so fast, and there needs to be a human in the loop. Because what these authors ended up finding out in an evaluation of 61 common e-consults ranging from things about abnormal imaging, hepatitis B, serology interpretation, and abnormal liver tests, there were some pretty good drafts of consults that came from a large language model. And about 3 and 4 of these were probably good. If not 4 and 5 were probably good to go to be used clinically. But at least 1 in 10 had some misinformation, and 3% or so were probably straight up harmful. And so unless there is a human, an expert, intervening to make sure that the quality of these e-consults is sufficient for prime time, then these aren't ready. So I think it's going to cut down in the overall amount of time that we can devote to e-consults, but we're not going to be able to just plug our patient's information into ChatGPT and hope for the best. Research like this that we've been grateful to publish from this group is what's going to shape the way that contemporary hepatology practice is delivered, without a doubt. I'm excited about this study from Dr. Jason Lee. The incidence, frequency, and transplant likelihood of patients with pediatric acute liver failure. So how many of patients showing up with acute liver failure end up dying from that condition or requiring a liver transplant? So the overall incidence was 16.75 per 100,000 live births. This is a quotable number, and it is a huge advance to have epidemiology like this. I love having these statistics published in Hepatology Communications because it's the answer to a question that somebody is going to be asking on the rounds. What is the incidence of this condition? Now, how many people end up needing a transplant? 8%. How many patients died in the 3 years after their acute liver failure? 18.7%. So this is the overall rate of outcomes for these patients. Ideally, you're transplanting before the patient dies. Sometimes comorbidities prevent that sort of thing. But this is the kind of number that highlights the urgency of research and improved multidisciplinary and multi-center care for kids with acute liver failure. And we need these numbers to justify the business case for new programs and certainly additional research. Again, excited that we were able to publish this. Dr. Darkangelo with a hot take, and it is that physical frailty is the most important predictor of early mortality in hospitalized patients with decompensated cirrhosis. Small cohort, but important study. And even though it's small, we see a huge signal. So this is a group that evaluated patients led by Dr. Darkangelo and Dr. Zanetto in Italy. They enrolled 127 patients who were admitted with decompensated cirrhosis, and they did the liver frailty index, Dr. Jennifer Lai's LFI. And lo and behold, what you end up finding is that even after looking at other factors like child class, child C versus AB, the presence of ACLF MELD score, the single largest signal for early mortality comes from the LFI. So the LFI, which is a composite measure of hand grip, chair stands, and balance. First of all, it's a highly selected group. They have to be able to do these things, right? We're not talking about bedbound patients, but you can imagine what being bedbound means for prognosis if we're inferring that from this study. So now that we know that we have to get these patients up to demonstrate their physical function with this performance measure, we see what the underlying population might look like. And the interpretation of these data, it reflects a number of things. Not only their nutritional status, the presence of sarcopenia, but probably also their cognitive function. And so with one measure, you communicate with great economy a global set of deficits. I think that it communicates not only risk, but also a mechanism. And it highlights the critical importance of early nutritional support, intensified therapy for hepatic encephalopathy that is almost certainly playing a role here. And where that therapy is already intensified, it is a clarion call for additional research, for additional interventions that can further optimize the condition of these patients. Dr. Stan Driesen leads a multi-center study, this time largely from the Netherlands, evaluating two-step care pathways for advanced MASLD in primary and hospital care. So this is a mixed sort of setting. And what we learn here is that the optimized approach to referring patients with advanced liver disease to the hepatology clinics where they stand to benefit from that referral depends on multi-step risk stratification. And the optimized approach that they suggest is using the MAF5 with a score greater than or equal to 1, followed by VCTE, commonly employed as FibroScan, where at least patients with greater than 8 kilopascals are more likely to have advanced liver disease. This is a sensitive and specific way of accurately involving the right patient at the right time in the right place, which is liver clinic. In their hands, in this cohort of 595 patients, where 10%, 9.4%, were at risk for advanced fibrosis. The MAF5 outperformed FIB4, but I think you'd be doing fine in either way. And so the key lesson here is that if you're going to apply a measure like FIB4 at the level of the population, its performance, its test characteristics, the Bayesian post-test probability is insufficient to accurately identify patients at risk for advanced fibrosis. And that's why, after you've gone through that first pass, taking people with relatively low risk, you then increase the yield or the benefit of that referral by applying that second sequential test, in this case, VCTE. And if you had to choose an alternative, if you didn't have access to FibroScan or VCTE, this group is suggesting ProC3 as the most effective alternative blood-based second test. There's a research letter from Dr. Caleb Miller using the NASH CRN group study. Histologic severity is identical between normal weight and overweight adults with MASLD. So like once you've diagnosed somebody with fat in their liver and steatohepatitis, we definitely need to work on lifestyle modification, but the histologic severity at that moment is what matters the most to their overall prognosis. And just because they may have a lower BMI, at the point that you've diagnosed them with this condition, that BMI doesn't play a role in their long-term prognosis. Once you have to do the risk stratification, that two-step classification to understand who's at risk, and then implement in a patient-centered and patient-specific tailored way the kinds of interventions that can bend the curve of the natural history of their condition. Dr. Nihar Parikh, my friend, my associate editor, conflict of interest here. He enrolled patients in a matched case control study to evaluate the performance of methylation scores for HCC detection. And lo and behold, methylation scores using cell-free DNA with AFP showed very promising early stage HCC detection. 92% sensitivity, 73% specificity. This is a new day has dawned when it comes to HCC screening. And if these tests are covered, a blood-based test is simply going to help us get more patients screened than waiting for an ultrasound. And so there's plenty of reason to be excited about the coming wave of blood-based biomarkers that are going to help us detect HCC early, which we all know is what's going to help us save more lives. Well, I am excited about these papers. I hope you're as excited to read them as I am. Every time I see these papers come online, I get thrilled to share them with you. I hope you read them. I hope you enjoy, and I'll see you again here, same time, same place next month.
Hi everyone, I'm Carmen, and I'm very excited to share with you the latest studies in the current issue, which revealed how various factors and cell types in the liver microenvironment contribute to liver diseases. First study I'm going to share is on a gut microbiota metabolite, indole 3 propionic acid IPA, which influences MASLD development by modulating ER stress. IPA supplementation could reduce hepatic lipid accumulation and reduce liver damage and steatosis development in mice. The second study that I'm going to introduce is on a hotly pursued area on mRNA modification. It is a new layer of epigenetic regulation which could influence gene expression. In the study, the enzyme NET10 was found to regulate the stability of a gene FHIT through AC4C modification in mRNA, and this enhanced T cell activity, contributing to the development of steatohepatitis in mice. And a third study that I'm going to share with you, it's on PERK signaling and its downstream effector get GADD45A in hepatic stellate cells. This pathway is important for hepatic stellate cell activation and fibrosis in mice. A final study I'm going to share with you is a very exciting study which highlight the crosstalk of liver sinusoidal endothelial cells and CD8 T cells through interleukin 15. So this actually enables CD8 T cells in their activations, persistence, and also responsible for the inflammatory activity in alcohol-associated liver disease (ALD). So this signaling can be perturbed, and it can be a therapeutic approach or strategy for alleviating the inflammation in alcohol associated liver disease (ALD). Enjoy the study.